And here is your question. Okay, so if you've read and understood considering it clinical examination, close your eyes and walk me through exactly how you will carry out your examination. Your time starts now.
Good morning. I'm candidate number 4. May I know your name and age, please?
Yes, I'm Victoria, 62 years old.
Hello, Victoria. How are you doing today?
Yes, I'm good, thank you.
So I've been told to examine a swelling in your neck. Do I have your consent?
Yes.
I'll just wash my hands.
Okay.
So, inspection of the neck swelling. Can you just point out where exactly you're having your swelling?
Yes, here.
In front of the neck.
In
Okay.
front of the neck.
Yeah. So,
yes.
So,
what about exposure before you go for the general inspection?
Exposure up to just below the sternum. I'll expose it just below the
So
sternum.
you'll ask her, so can you button up your first two buttons so that I can examine you? Good. Continue, please.
Yeah. Do you need a chaperone, Victoria?
No, no,
For
no.
exam?
No, not for this one. Continue, please.
I'll continue. Yeah, on inspection, I can see visible neck swelling in the front of the neck, no dilated veins, no scars. So, Victoria, is it possible for you to just deglute something? That means just to
Yes, swallow your saliva.
swallow,
Yes.
swallow
Yes.
your saliva.
Yes.
Yeah.
Done it.
So I can see the swelling is moving up and down with the swallowing.
Yes.
Victoria, is it possible for you to protrude your tongue?
Yes. Doing it.
Okay, I don't see that the swelling is not moving up with the
protrusion of tongue.
Protrusion of the tongue.
Good. Continue, please.
So I would like to do the palpation part of it. First, I'll palpate from behind. I'll look for the.
Oh, before you go behind, you'll give a warning to the patient that I would have to examine
I
you
would
from
have
the
to
behind.
examine from behind.
Yes.
I hope that's okay.
Yes.
Yeah.
Yes.
So I'll look for the local rise of temperature.
Yes.
I will try to palpate each lobe of the swelling by pushing one lobe to the other side. If I want to examine the right lobe, I'll push from the left side so that the right lobe becomes prominent. I will look for sight. I would look for the size. I would look for the symmetry of both the lobes.
Yes.
I would look for the margin.
Very
I
good.
would look for the underlying skin and scars. I would also look for whether the lower margin is felt or not, whether it is going below the sternum or is it restricted to the neck.
And the movement of the overlying skin, yes.
Movement of the overlying skin, whether the skin is pinchable or not.
Good.
And the same thing, I'll again ask her to deglute, swallow, so that I can see the movement.
Yes.
And
you ask her to drink, take a sip of water.
Yeah, take a sip of water.
Yes.
After the palpation from behind, I'll again come back in the front. I'll come back in the front. I'll observe for a few other things like any swelling in the leg, like pretibial myxedema.
Yes.
I will ask her to put her hands in front and put a paper over it so that if at all there is any tremor, fine tremor, I'll observe for that.
Yes.
I'll observe for lid eye signs like lid lag, exophthalmos,
Yes.
proptosis.
Yes.
I'll see the eye movements as well.
Yes.
Um,
And you'll feel for the trachea.
yeah, I'll feel for the trachea whether tracheal deviation is there or not.
Yes. You'll palpate the lymph nodes. Where exactly?
Yeah, I'll palpate all the lymph nodes. First submental, submandibular,
Yes.
retroauricular,
Yes.
anterior cervical, that is
Yes.
in the front, just above the
And the supraclavicular, the most important.
supraclavicular lymph node.
Okay, what else
Posterior
would you do?
superficial cervical. I'll look for the bruit over the thyroid. I'll
For
palpate
bruit?
her. I'll palpate her pulses.
Yes,
and
you'll percuss as well the sternum.
Percuss the sternum to look for the any retrosternal extension of
Good.
the thyroid.
Then you'll auscultate for the bruit. Then
Auscultate for the bruit.
have you missed anything else?
Uh,
Eye examination and hands. General examination of the hands and the eyes.
General examination. I look for any nail changes, clubbing.
What would you see in the eyes?
Eyes, I'll look for lid lag, proptosis, any.
Yes.
I'll see for eye movements. I'll see whether the lid is lagging behind the movement of the eye.
How would you carry out this examination?
I'll just, Victoria, would you mind if you can just look at my finger?
Yes.
I'll just move my finger up and then I'll slowly move my finger down.
Yes.
And I'll observe for the
shape. Yes. Good. Continue, please.
Yes. What did you say, ma'am? I didn't
H shape. H.
Head shape. Yeah, head shape for all the movements.
Yes.
And when I'm I can also, when I'm examining from behind, I'll also look for proptosis.
Yes. Yes. And there is another test you're missing out. You'll ask the patient to straighten out the arms in front of them, and then you'll
put a paper over.
Yes. How?
And fine tremor. And look for the fine. I'll ask her to straighten both her hands, and I'll put a paper over both her hands, and I'll observe for any fine tremors.
Yes, very good. Okay. Right, and you'll move.
So,
restriction of over, yes. Just few seconds left. All right. Okay, please summarize your examination.
So here is Victoria, a 52-year-old lady who presented with swelling in her neck from past 8 months. On inspection, the swelling is localized to the front of her neck. It is moving with swallowing. It is not going up with the protrusion of the tongue.
Good.
There does not look to be any retrosternal extension. That means the lower border is seen. Skin over it is normal. There are no scars. No local rise of temperature. On palpation from behind, margins are well defined. It is a symmetrical swelling. Both the lobes can be felt. It is moving with the deglutition, with the swallowing. Trachea is in midline. Skin over it is normal, pinchable.
Good.
There are no scars.
Yes, and no pigmentation on the overlying.
Pigmentation over the overlying skin.
Good. Did you hear any bruit on auscultation?
I
no.
Could not hear any bruit.
Yeah. Very good. So, considering your examination, what are your provisional and differential diagnosis?
My first provisional diagnosis is multinodular goiter.
Very good. And then continuously, yes. Second and third.
Possible diagnosis would be Hashimoto thyroiditis or thyrotoxicosis due to
Graves' disease. Okay.
Graves' disease.
Thyroid neoplasm or thyroiditis. Okay, the last one. Please tell me, how do you plan to manage your patient?
First, I would like to do blood investigations like thyroid.
Triple assessment. Continue with that. What do you mean by that?
Triple assessment means clinical, ultrasound, and blood test or FNAC.
Okay, taking history, doing examination, then doing ultrasound, and then fine needle biopsy. Okay, what blood tests would you include for the examination?
I would like to include thyroid function test, thyroid peroxide antibodies, TPO antibodies.
Yes.
I would also like to do calcium and parathormone tests.
Okay. Right. You go ahead, you do the triple assessment, and as part of triple assessment, like we discussed, you'll do FNAC, fine needle aspiration. After 2 weeks, the same lady comes to you with the report in her hands, which says that they are unable to differentiate carcinoma from adenoma. What do you understand by this report?
So at this point, I would like to counsel the patient.
And sorry, I want to add, it shows a follicular cell carcinoma or the tumor and unable to differentiate between adenoma and carcinoma. Now, please tell me.
Yeah, so I would like to counsel the patient. Victoria, as you know, the report has come out to be follicular neoplasm, and on the fine needle aspiration, we are unable to differentiate whether it is a benign, that means it is adenoma, or it is a malignant carcinoma. So the best line of action would be to do a thyroidectomy. And
no, before that, please. Because now you are unable to differentiate between adenoma and carcinoma. So what would you do? What would be your next step?
The answer I know is thyroidectomy and thyroid replacement therapy, hormone replacement therapy, and send it for further histopathological examination.
Okay, even if you'll go for the thyroidectomy, you would have to discuss the matter with the MDT oncology team, and then you'll decide for the thyroidectomy. Okay, considering if it was follicular carcinoma, or you could say follicular carcinoma, but unable to differentiate between adenoma or carcinoma, then what would be the survival rate of this patient? How much would be the 5-year survival rate?
5-year survival rate is good.
Very good.
More than 90
plus.
95%.
Very good. Yeah. Okay, in this situation, would you rather rely on the histopathology report or the cytology of the result?
No, I would rely more on the histopathology
Very
rather
good.
than on
Very
cytology.
good. Okay, what is the demarcation between carcinoma and adenoma in your according to your understanding? It will become part of little histopathology or the surgical pathology station. But if you can tell me, what would be the demarcation? How would you know on based on histopathology report? If it is adenoma, it will be encircummed, and if it is carcinoma, then it will be penetrating or invading the tumor capsule or the surrounding vessels, right? So it's simple. Yes. Yes, this is what you have to keep in your mind. Good, very good. Thank you. Thank you.